Well, good evening, everyone. Welcome. Welcome to our webinar this evening. My name is Neil McCarthy. I'm the Director of Public Relations and Communications at the Archdiocese of Toronto. I'm coming to you tonight from the bedroom of my 7-year-old daughter, Quinn McCarthy, who could burst in at any time. So stay tuned for that, but it's great to have you all with us. We've got about over 155 people that are with us so far, and likely some more that will still be joining us in the next few minutes. And I know that we've got a lot of people from the Archdiocese of Toronto here, from the Catholic community. We also have many people who are with us on the webinar tonight from across the country. So we want to make a special welcome to you wherever you're joining us from. And those of you who aren't Catholic, but maybe just interested in this topic, of course, you're most welcome to be here. We're really excited to have so many people interested in a really important topic that we're going to talk about this evening. And we've got a super panel that's put together, and we're going to have some great insights as we talk about Bill C7, which is formally known as the Act to Amend the Criminal Code regarding medical assistance in dying. And it's an important discussion that we're having in this context right now with COVID-19, and we're talking about, isolation and people who, many people who've known someone or even lost someone who has suffered from COVID-19, and our inability to be close to people who may be in hospital or long-term care facilities is a real challenge right now. So that whole conversation about life is a really important one that's taking place right now. We hope that we're going to have some insights that will be both educational and give you some food for thought. And so we're going to get right to it, take about an hour or so to talk about this. We'll have a question period at the end, and I'll do a few housekeeping items right off the top as we get started. Your mics, if you're watching from home or, at your own personal device there, they're muted. So you're not going to be able to interject or make a presentation tonight unless you're a panelist. And so just so you know, if you're walking around or you have people come in the room where you're watching, that's not a problem. We can't hear you. We have some PowerPoint slides that we will share on the screen periodically throughout the presentation, more as notes for background on the topic. And you'll be able to download a copy of the PowerPoint slide presentation before the end of the webinar, so we'll make that available before we're done tonight. So if you're taking some notes, don't worry, we'll send the PowerPoint deck to you before we're done. If you have questions, you'll see you have a little control panel. It's got an orange arrow on your screen, and you can either expand or minimize that. And it has a few different options about audio, and questions is one of the panes. And if you open up the question pane, that's where you pose your questions. So your questions will be sent to us. And after we're done our kind of formal discussion, we'll have a period of time for questions. And so you can pose those at any time. And we're going to try to get to as many as possible, depending on how our time is and how many questions we have. We may not get to all of them, but we'll do our best to get to as many as we can. For those of you who may be having audio issues, if you're trying through your computer to go through your speakers, sometimes with GoToWebinar, that can be a challenge. And so if you do have a problem, on that control panel, you can click on audio, and it also gives you a phone number that you can call in with a PIN that you can enter in, and you can listen in through your phone, and you can watch through your computer. So that's another option if you have any audio problems at home. And the final point I'll make in terms of housekeeping is some of the language or terms that we use tonight for those who are Catholic may not always be those that you're familiar with in terms of how we approach this issue from a Catholic perspective. For example, I just mentioned the legal name of the bill, medical assistance in dying. That's not a term we tend to use in the Catholic community. We talk about euthanasia or assisted suicide, but we may be referring to legislation or specific parts of the legislation or the issue. So if you hear the word medical assistance in dying, then recognize that we're trying to use some of the secular terms at times that are being used in the conversation as well. So that's important to remember. I'd also like to take a quick opportunity to encourage you at some point after we're done tonight to visit a website that's been put together called helptheliving.ca. And there you can get a little bit more information about how you can be engaged. It's a very easy process if you'd like to send a letter to your local member of parliament. It takes about 20 seconds or about the time we're taking these days to wash our hands. So if you want to do that, we encourage you to do it at some point. If you're concerned about this issue, there's some more information on that website, but we'll talk about that again at the end of the evening. But just encourage you to also not only be educated tonight, but take action and have your voice heard by your local elected official as well. So before we introduce our distinguished panel, we are very fortunate and blessed to have the Archbishop of Toronto, Cardinal Thomas Collins, with us this evening. And so I was wondering if Your Eminence, you might be able to lead us in some brief opening remarks and perhaps a prayer as we start this evening. Good evening.
Well, thanks, Neil. Thank you very much. And I'm very glad that we're putting on this webinar to help people to become more and more informed about what is truly an issue of life and death. We are so concerned of this pandemic about people dying, and particularly people who are very, very vulnerable. Well, this is an issue we face beyond the time of the pandemic. It is what is called, as you say, medical assistance in dying, which is not really what it is. That's the term they use. But we value life in the first moment of conception, a natural death. And we each come to that time, and in due time we go to the Lord. But this use of, I find it especially, it is an issue of trouble. We're using language in ways that sort of slip things through, which are most problematic, to put it mildly. And I think all of us, when we were involved in this debate in the early parliamentary experience, we were saying these various protections, these safeguards, they call them, where they're going to be snapped off very quickly, and that's what this is the issue at hand right now on Bill C7. We have a double thing. We have Bill C7, we got Bill C8, which is also very problematic about so-called conversion therapy, which of course is another problem. But this is an issue of euthanasia. And as we expected, as we predicted, we can say, we told you so, the government is now coming to widen out this thing, and we see where that has led other places. So it's very important to become informed about it, and being informed to act well about it in an organized, thoughtful way, with clarity and charity. And so I'm very glad people are joining to know more about this subject, and very thankful for the panelists who are allowing for that. So let's begin with a little prayer. In the name of the Father, and the Son, and the Holy Spirit.
Amen.
God, we ask you to bless us and guide us so we know your will, and do it faithfully, that we may truly be there to defend and to advocate for, to protect human life from the first moment of conception until natural death. We ask this through Christ our Lord. Amen.
Amen.
In the name of the Father, and the Son, and the Holy Spirit. Amen. Thank you.
Thanks very much, Your Eminence. We really appreciate your leadership and your presence here this evening. I'd like to take a moment to introduce our distinguished panel. We have a couple of them that are with us, if you're following on your computer, that you can see on the screen, and a couple of them that are also joining us by phone as well. And so I'd like to introduce our panel. Start with, on the phone, Taylor Hyatt is a disability rights advocate and board member of the Euthanasia Prevention Coalition. Great to have you with us on the phone tonight, Taylor.
Thanks for having me.
And I'd like to also introduce on the phone from Alberta, Christina Lamb, who is an assistant professor of nursing at the University of Alberta. She's also a bioethicist and the founder of the Aletheia Conscience Project, which researches conscience rights issues for healthcare professionals. Welcome, Christina.
It's my pleasure to be here. Thank you.
And we also welcome on the screen Dr. Moira McQueen, who is the director of the Canadian Catholic Bioethics Institute. She's also a moral theologian at St. Michael's College at the University of Toronto. Dr. McQueen, welcome.
Thank you, Neil. Hello, everybody.
And finally, we want to welcome Derek Ross, who is the executive director and general counsel at the Christian Legal Fellowship. Good evening, Derek.
Good evening. Great to be part of this. Thank you, Neil.
All right, well, let's jump right in and talk a little bit about background on this. I mean, this isn't a new bill. It's a new bill, I guess, in terms of this legislation, but it's not new that we're talking about legalizing euthanasia in this country, because it is already legal, and it looks like it's expanding from the desire of the current government bill. So, Moira, maybe you could start us off, for those who may not be as familiar, to give us a bit of background on what the Catholic Church teaches about euthanasia and why we take that position.
Right, and the Cardinal launched us right into it by talking about how the Catholic Church views the sacredness of life from conception until natural death. So automatically, if you like, excluding abortion at one end, euthanasia at the other. And Catholic teaching has been very clear on euthanasia. As far back as 1956, Pope Pius XII talked about how wrong it was to deliberately end a person's life for those particular reasons. And in 1980, the Congregation for the Doctrine of the Faith wrote what they called a Declaration on Euthanasia, but very strongly worded. And people sometimes say, well, did the church not write anything before that? And yes, it did, but it actually wasn't needed almost until, last century, the 20th century, in terms of the euthanasia movement making some progress, and then the church restating what it had always believed, and now in writing, so to speak, in things like the Declaration, talking about how it's intrinsically wrong to end MD's life. And it specifically stated whether it be an embryo, a fetus, an ill person, in any category at all, that deliberate taking of life, no matter for what reason, no matter how compassionate it may sound, is intrinsically wrong. And so, and of course, Pope John Paul II, in Evangelium Vitae, his whole trajectory about the culture of life, and very firmly stated in section 65 in that particular encyclical about, he actually used the words, I confirm how wrong it is for people to deliberately take an innocent life. And that meant through euthanasia or any other act, in fact, that had the same result. So Catholic teaching really has never wavered. It really has held this particular principle that it's absolutely wrong to take an innocent life deliberately. And I think that clarity is very useful for us. There's no ands, ifs, or buts when it comes to euthanasia. Gives us, I think, a very strong platform, because we're talking about the sanctity of life. It's not at all a negative principle. It may sound negative, but the whole reason for its being in place is because of how we value life. And that's where the stance of the church is coming from.
No, thanks, Maura. It's always hard to kind of crystallize the teaching of the church into a little 90-second or 2-minute blurb, but you've done a great job on that, so thank you. And there's, interesting in this conversation, there's a lot of other faith communities as well that share the concerns that we're going to be talking about tonight, and also kind of talk about the sanctity of life in their own faith tradition as well. So thank you for that background. Derek, let's turn to you from a legal perspective. For those who may not be kind of following this as closely as you likely are, maybe you could give us a sense of what the current state of affairs legally on euthanasia in Canada is, and how Bill 7 might change that if it becomes law.
For sure. So until very recently, euthanasia has been illegal in Canada. There was a complete ban on assisting in suicide, and that included in the medical context. That changed in 2016 when Bill C-14 was introduced and enacted. That, of course, was in response to the Supreme Court of Canada's decision in Carter. That was a case that we at Christian Legal Fellowship intervened in. A number of other organizations did as well. And in that case, the Supreme Court decided that an absolute ban on euthanasia was unconstitutional because it denied individuals their right to liberty, their autonomy. And so Parliament had to respond with a law that would be more flexible, that would allow individuals to seek assistance in dying. That's the euphemism now that we're talking about. In other words, Parliament was charged with the task of legalizing euthanasia. So they did that in 2016, and they placed some parameters around it. And that is what the law is currently. There are some parameters around euthanasia. It's an exception to the criminal code prohibition, which still generally bans assisting anyone in committing suicide. But there's now an exception for medical assistance in dying, which allows an individual to obtain the help of a physician, either a doctor or a nurse practitioner, to effectively terminate their life through lethal injection or through the administration of toxic medication, basically. And it's important that we bear that in mind. When we talk about medical assistance in dying, we're not talking about withdrawing life support or ending life-sustaining treatment. Those things have always been legal. And that's why this terminology, medical assistance in dying, muddies the waters a little bit. What we're talking about with medical assistance in dying is terminating life, ending life through a lethal injection. And currently, in order to access that, a patient must have a grievous and irremediable illness, that's the term used in the legislation, that causes intolerable suffering, and that their death, their natural death, must be reasonably foreseeable in order for them to access euthanasia. And the reason for that was, and there was a lot of parliamentary debate at the time, that the government in 2016 wanted to ensure, and they were adamant that this would place an appropriate limitation around euthanasia, that it was only to be used as a means of hastening an already foreseeable death, that it would only be available to a patient who is dying. And the thinking was, the argument was, that this would just help hasten that passage into death, which was already taking place. But that term, reasonably foreseeable death, in and of itself is a very, very open-ended term, and it has already been interpreted very flexibly, concerningly so, very broadly. And courts already have said that it doesn't require a patient's death to be imminent. So even before C7, this safeguard, as it was called, was not really acting as much of a safeguard. But at least it was there. At least conceptually, euthanasia was designed to be limited to the quote-unquote dying process. What Bill C7 does, though, is fundamentally redefine that and removes that reasonably foreseeable criterion, so that now any patient, regardless of how many years they have left to live, even if they are not dying, even if they don't have a terminal illness, even if their underlying condition will not and could not possibly cause their death, they can still access euthanasia if they meet the other criteria, such as the grievous and irremediable condition, which is largely something that is being determined from the patient's perspective. So that is not really acting as a particularly objective safeguard. And the result of that, of course, is been put really well by disability advocate Dr. Catherine Frazee, where she says that Bill 7 is transforming MAID, euthanasia, as an alternative to a painful death under the existing law into something very different now, an alternative to a painful life. So that it's something that can be used to end life, end suffering as a general solution to many different kinds of suffering. And that's what's so troubling about this bill, is it's completely transforming euthanasia as we understand it. It does a few other things as well. It's removing some other safeguards, which we can talk about. But conceptually, that's the big shift that we're seeing with C7.
No, that's great, Derek. And again, it's not easy to compartmentalize all that in a couple of minutes, and that's a good view from kind of 30,000 feet. So thanks for that from the legal perspective. Christina from Alberta, you spent a lot of time, obviously, studying this, and you know, your knowledge is extensive in terms of nursing background as well. Maybe you can help us understand some of the specifics for medical professionals who are involved with euthanasia in Canada. For instance, you know, what professions are involved? What do they have to do? Can they refuse to participate? Can you shed some light on that for us?
Certainly, thank you, Neil. So I think off the top, I just want to point out two things. One being that in Bill C-14, the MAID or euthanasia legislation, it reaffirms in the preamble that everyone in Canada has the freedom of conscience and religion under Section 2 of the Canadian Charter of Rights and Freedoms. And in Bill C-14, it was supposedly, whereas nothing in that act is supposed to affect the guarantee of freedom of conscience or religion. And I want to point out as well that federal legislation does not force anyone to provide or help provide medical assistance in dying, or as we call it, euthanasia. It's important to note that for various reasons, which I'm going to explicate further. So first off, when we talk about professions that are involved, there are quite a few professions that are involved. So nursing, medicine, and pharmacy. And there are others, but these would have the most direct involvement. And there's other people that could be involved we don't necessarily think about in certain ways, because there are people, for example, those in regulatory or organizational leadership roles who have to create and monitor policy provision and evaluation of euthanasia for their healthcare professionals that they oversee and employ, as well as patients. And then finally, there are also some instances where people that we may not necessarily always think about at the forefront, but also will be involved, such as interpreters, because there have been cases that have come up in the literature where an interpreter might have to, quote unquote, translate whatever a provider, a healthcare provider, whether it be physician or nurse practitioner, is conveying to the patient requesting euthanasia and that sort of thing. And so it can play out that way as well. Now, in terms of what healthcare professionals have to do if they are involved in some participatory or provisional role with euthanasia, I'll start with nurses. And so there are two classifications of nurses that may be involved. So the first, as you mentioned already, Derek, is nurse practitioners. They occupy the same role that a physician would, because they can be providers of the act of euthanasia, whether that be providing patients with a lethal substance to take their own lives, or actually giving a lethal injection themselves as a provider. They also have the responsibility to assess patients who are requesting euthanasia. Registered nurses, a different category of practicing nurse. They can also be involved in more of a participatory role. So some of the things that they may be involved in, and this is not an exhaustive list, but they may assist in assessing for competency for patients who request euthanasia, providing information about euthanasia to patients and families requesting it, coordinating the whole euthanasia process. That could be technical, such as preparing equipment and IV access for medication delivery, coordinating and informing healthcare personnel related to euthanasia, documenting nursing care provided, supporting patients and families, and providing post-death care. So it could be quite involved. And then when we talk about nurse practitioners, I've already mentioned, and the same with physicians in their role, but then I'll also mention pharmacists, because they will be involved in fulfilling the prescription for a lethal dose, whether that be for the patient to take themselves and or a provider who would be administering the lethal dose. So those are some of the ways. That's just a broad brushstroke of what can happen for healthcare professionals in Canada. Now, I think you also mentioned, can they refuse to participate? Yes, for several reasons. One being that you have a chartered right to freedom of conscience and religion in this country, which is also a universal right, and the Declaration of Human Rights and Freedoms under Articles 1 and 18. Something else to remember, though, in the Canadian context is that healthcare bodies are regulated in our country, so most of those have a code of ethics. Now, for the Canadian Nurses Association, there is a pathway involved in terms of expressing an issue of conscience and a conscientious objection. So there's a whole pathway, if you will, for nurses and nurse leaders to follow, because the expectation from the Canadian Nurse Association is that nurse leaders will support any kind of frontline nurse to make a conscientious objection, and they are supposed to help them and make sure that they are relieved to providing that controversial care. And with respect to nurse practitioners, there's that includes them as well. They can make a conscientious objection. And finally, with physicians, the Canadian Medical Association talks more about conscience specifically with relation to the physician's role, and they emphasize that actually all physicians have to respect their colleagues' conscience, regardless of whether or not they have the same perspective on certain issues, such as euthanasia. And at the same time, the Code of Ethics explicates that physicians are able to share with their patients if there's care that they think that they cannot provide them in order for them to have a really open and transparent conversation about that. And by far and large, across jurisdictions in Canada, provincial and territorial jurisdictions in Canada, physicians are able to also conscientiously object. However, of course, as we know, the exception being Ontario, in which physicians have been unduly restricted, and they have what we call obligatory referral requirements, in which they have to potentially refer a patient for euthanasia up to including ensuring that they find another provider who will commit that act.
Well, thank you, Christina. That's a great overview from the medical perspective. And I know it's interesting, and what we tend to hear sometimes in the public conversation, sometimes in the media, or even when governments present the issue, they talk about, well, you don't have to do it if you don't want to do it. And I think we talk about that ethical discussion around a referral for any medical practice is in the eyes of nurses and doctors and those who are involved, as you've mentioned, participating in that. So we're going to likely get into that a little bit deeper, not to mention the fact that if we want to confuse you some more for those who are, trying to learn more tonight, you've got a federal law, and then you've got local provinces interpreting many of those laws when it comes to things like conscience rights and delivering healthcare at the local level. So there's some interesting dynamics at play there, where you're working both with the federal government and the provincial government. So thank you for that. Taylor, hopefully you're still on the line. Just wanted to get your perspective as someone from the disability community. Can you explain to us a little bit how disability rights advocates have responded to the arrival of euthanasia in Canada?
Well, for disability rights activists, this is nothing new. The disability rights movement has been opposing assisted suicide and euthanasia since the 1980s. Around that time, activists lost some important court cases related to the withholding and withdrawing of medical treatment. And since Bill C-14 came into effect, it's been this strange mix of trying to track how well the program has functioned, find the flaws in it, communicate them to legislators and also to the public. That not always easy to do for a couple reasons. One, the average person has difficulty accessing legislatures and academia where a lot of the conversation takes place and where a lot of the new ideas come out. And second, most people wrongly perceive the bill as an expansion of autonomy, which I'll touch on a bit later, and disability and illness are seen as a lack of dignity, hence the assisted suicide supporter tagline that the procedure enables you to die with dignity. But what about providing resources needed to live with it? I will say this until my face turns blue, that disabled people do not have to die to be dignified. Another kind of barrier in our way is the popular perception of these procedures that is not helped by the media. Journalists, unfortunately, don't know how to talk about disability as anything other than suffering and pity. People with disabilities are always, look at the pandemic, they're called vulnerable and in need of care, instead of a group of people who need their rights recognized. Vulnerability is not inherent to one's disability status. Vulnerability is something that is created by your circumstances.
No, thank you. Thank you for that. Very eloquent. And that's part of the reason we wanted to have these different perspectives, someone from a medical perspective, from the disability community perspective, legal perspective, and the faith dimension as well. So there's a lot of different aspects that are involved in this. And I think this is a rich conversation. Let's talk a little bit about some of the issues within the bill. Derek, the Justice Minister has come out and said that, the government decided not to include advanced directives in Bill C7. Do you agree with that assessment? And maybe you could shed some light or thoughts on advanced directives just generally.
Sure. So advanced directives refer to this idea that you can enter into a written agreement in which you give advance consent to be euthanized in the event that at the time of being euthanized, you have lost your capacity, whether your capacity to communicate or even your mental capacity has been diminished by virtue of some type of condition. The thinking with an advance directive is you would still be able to access euthanasia in that context. And up till now, this has been extremely controversial, and rightly so, because one of the inherent problems with an advance directive is you can never be absolutely certain that it truly reflects a person's wishes in the moment. People do change their minds from the time that they sign a document up until the time that euthanasia might be administered. And we've seen this already in the limited data that we have available from Quebec, for example. Over 320 patients have changed their minds after submitting a written request for MAID. That is the data we have available from the Quebec oversight body, from one province alone in the last 4 years. So this is something that does happen. And up till now, advance directives have not been permitted. I say up till now because Bill C7 does, in my view, absolutely create and legalize in some contexts an advance directive. It doesn't use that terminology, but it waives the requirement that a patient give their final consent in certain circumstances at the time the act of euthanasia is administered, if they have entered into a written agreement with their doctor prior to. That is an advance directive. So I think it confuses the dialogue in the debate when Bill C7 is presented as not permitting something that, in my view, it does permit. Why is that a problem? Because again, we enter into this issue of individuals now may be permitted to enter into an agreement which may or may not reflect their wishes at the time of execution. And that's a real problem, that for the first time in the history of our legal system that we would be enshrining into our law an openness to the possibility of potentially involuntary euthanasia. That is a very, very dangerous line that we're potentially crossing here.
That's a really important point, I think, to make. And then when we hear about advanced directives, oftentimes the way that it's presented publicly, some stories that are out there is, well, of course people should be able to do what they want and this kind of thing. And I think it's important that we tell the truth about these things, and our language is important as well. And moving in that direction, Moira, you know, this proposed bill does remove some of the things that can slow down the current process of receiving euthanasia. And so, for instance, you know, Bill C-7 would require the approval of just one doctor to receive euthanasia rather than the two that are currently required. Could you give us some thoughts on that? You know, your reaction.
Yeah, I mean, again, it's such a total change from a legal perspective as well as from a moral perspective. I mean, there have always been good reasons for there being at least two witnesses for just about everything. But all of us can think of, you know, everything from having your marriage certificate signed, you need two witnesses. I mean, everything is about that. And it's really a protection for the person. Although in this particular case, it's making it look as if is to speed up the process to actually help the person. So again, we have that dichotomy. But you can just imagine, I think, the scenarios that could happen with one physician signing. The physician could be wrong, the person could be negligent, the person could stand to gain. I know the law tries to preclude that sort of thing, but the law isn't able to handle all these things. So there's very good reasons why there should be two witnesses. And it's not as if I'm saying here that, you know, that by saying, oh, there must be two witnesses, I'm actually agreeing to the procedure, because I most definitively am not. The euthanasia process is still completely wrong as far as I'm concerned, and from a faith perspective as well. But looking at it from the point of view of just what's planning to be enshrined in this law, I mean, I just can't see the Supreme Court sort of even, you know, seeing anything valid about this at all. The idea of two witnesses, you know, one to corroborate the other, to protect the person, to make sure the person signing on anything isn't being coerced or anything like that, at least as far as possible, has been a keystone of civil law and actually canon law as well, you know, which is where it comes in terms of signing a marriage certificate. So this is an incredible shift, and I think a lot of people are going to realize that although it is being said again as if to hasten the process and help the person involved, it maybe could do that, but the dangers inherent, I think, far outweigh that apparent convenience.
Thanks for that. And thank you, Moira. I think I mentioned two doctors. You mentioned it, corrected me, it's two witnesses. So thank you for that. I think that was right. So I'm trying to keep track of everything too, as things change here. So thanks. Christina, you know, you've got colleagues and friends and people who are involved in the medical field. Tell us a little bit about how medical professionals are affected by participating in euthanasia.
For sure. Thanks, Neil. So I think it's also important to relay the fact that there's also quite a bit of empirical research in this area. So I'm going to speak about the literature. When I say the literature, I by far and large will be talking about this empirical research elements. So I'm going to open this up with saying that basically lifting off what I said before about how, in essence, as you mentioned, Neil, in principle at least, every healthcare professional in this country, with the exception of undue restrictions on physicians in Ontario, in principle have the opportunity to have their conscience accommodated and to make a conscientious objection to participating in euthanasia and or providing euthanasia. However, the reality is there's a gap from these codes of ethics and into practice. What I mean by that is that I'm going to discuss a few different scenarios and some different healthcare professionals and how they're being affected by euthanasia and their participation in it. Also, I want to start the top off though by saying there are those that are not participating or providing euthanasia and are actually being negatively affected in so doing. Let me explain. So there are those that even if they do not participate, they live in a state of moral uncertainty. And I'm specifically speaking more so about nurses here because this is the body of the literature that really houses this, these scenarios and these problems. Because a lot of nurses, some nurses, are not being properly accommodated to voice their conscientious objections in practice. This can be due to a range of reasons, but there's one incident in some of the research that I've conducted where one nurse had to voice a conscientious objection to 5 different people to be, effectively heard because there aren't, I think part of the problem is that nurse leaders, while we state in our code of ethics that they are supposed to be supporting frontline nurses to make conscientious objections. That doesn't always happen. Now, I think to have a balanced perspective, I think that a lot of these nurse leaders, quite frankly, don't necessarily know conceptually what some of these concepts are, like conscience, conscientious objection, and I'll touch on that momentarily. But therefore, we have nurses who are now going to work and they do not always have the support that they need to make conscientious objections. So some nurses have reported feeling the need to quit, change practice areas, or live in a constant state of moral risk and fear because they will not be able to do what they perceive to be ethical in practice, in which they have the rights in this country to be able to refuse to do certain things. So those who are not supported are also at risk for human rights violations, and they may be actually experiencing them. So there's also some evidence from different jurisdictions in the world too that explicate that some nurses are feeling moral distress from participating in euthanasia. More nurses from other jurisdictions state that while they believe in euthanasia, they would not do it or participate in the act. Still more report that it is essential to have open conversations about patients' requests and participate in those discussions with patients in order to dispel fears, myths, and these conversations can often lead to patients changing their mind about requesting euthanasia, as they didn't know about what palliative care options mean, or what pain control is, or how they could have access to it. So when we talk about other groups, there's more limited research around the experiences of pharmacists and their perspectives, but the studies that do exist show us that many believe that they have the right to choose and would not be involved in, and actually more so have reported in the literature that they would not, rather than be involved in participating with euthanasia. Physicians themselves too, there have been studies to indicate that now this is interesting as well, because some of the research that has come out of Quebec, where prior to euthanasia being legalized in that province, and they only have a physician assisted death arm of euthanasia in Quebec. So doctors have to perform the Euthanasia Act there. So interestingly enough, in a survey prior to euthanasia being legalized in that province, there was a high number of physicians who said that they would be open to performing that act. After it was legalized, there were, and post studies after legalization, many physicians have said those that would do it would not do it anymore because of the emotional burden, psychological distress that it placed on them. And predominantly, most of the research coming out of Quebec with respect to physicians, all of them regardless, well, the majority of them regardless if they support euthanasia or not, felt that they had the right to conscientiously object, and that was something that had to be maintained across the board for all physicians. So beyond euthanasia, though, there are studies on related issues. And I want to talk about one because I think it's really important, and I don't think this is necessarily stressed enough in the conversations around euthanasia, but it's relevant to the authoritative processes that exist in the world related to euthanasia and or conscientious objection specifically. So there are studies that have been done in the Scandinavian context where on phenomena known as stress of conscience and troubled consciences. So nurses and other healthcare professionals who cannot use their conscience, and by that I mean voicing their conscientious concerns, dialoguing with their colleagues about conscience issues, and they're often dismissed, ignored, or silenced as a result of not being able to do so. Because let's remember that, for example, in Sweden, making a conscientious objection is against the law. So interestingly, these researchers went and explored conscience empirically. So they find that when this happens, when healthcare professionals are dismissed, ignored, or silenced, it results in them distancing themselves from ethical dimensions of their practice, deadening their conscience, as in blanking it out and not paying any more attention to it, changing clinical areas and leaving the profession. Some interesting anecdotal evidence that came to me from a researcher of moral distress in the States recently, the last year or two. She told me that there was evidence surfacing where healthcare professionals who cannot voice their conscience concerns to issues of moral gravitas in healthcare practice are committing self-harm. So I want to point out finally a couple of things. What this research reveals overall is there is a large ethical gap, especially with respect to a lot of literature coming out related to nurses, because they are seeming to be in the literature to rely heavily on their patients' requests and views as a motivation for making their ethical decisions. And I think something else I wanted to point out, I know I've been taking up quite a bit of time here, but across the empirical literature, so those are qualitative and quantitative studies, but also across the theoretical literature, such as philosophy, theology. There's a ton of rhetoric and tension in that literature about conscientious objection And that tension has increased over the last couple of years. It's really important to note, though, in the context of euthanasia and because of conscience rights, that much of the problem within that literature, the tension that exists in there, is because conscience is being neglected. It is not being associated with conscientious objections. So people in healthcare, by far and large, do not realize that their human right to freedom of conscience is not being paid attention to, and there's lack of understanding of what conscience is across healthcare sectors, and therefore, when you make a conscientious objection, it's not necessarily something that is grounded in an understanding of how important that is. So I think it's really important as well to acknowledge these points in literature, because, you know, similar to Moira, in doing these investigations, you know, I'm 100%, you know, believe that euthanasia is ethically wrong, but in order to be able to talk about it and to support healthcare professionals to move forward and doing something about it and advocating for themselves and opening up the dialogue with the colleagues that they have, we need to start talking about the fact that there's just so little attention paid to conscience across the literature, and this is affecting people who are participating in euthanasia who may or may not know it.
Oh, thank you. I mean, obviously you spent a lot of time on this, Christina, and can probably spend a whole evening sharing some of those insights on the study that you've been involved in. So thank you for that. Taylor, let's go back to you. Can you share a few brief thoughts on how well people with disabilities are represented by government and how that fits into this issue in the bigger picture?
Well, as I said before, a lot of these conversations are taking place in institutions that are difficult for the average person to access, even more so for people with disabilities who might have any number of barriers in being able to travel to government centers or otherwise communicate with their representatives. And so the way the government has handled this issue, there are a lot of misunderstandings. To name a few, pardon the knot in my tongue, the new act says that a mental illness is not considered to be an illness, disease, or disability for purposes of euthanasia and assisted suicide. But nothing has been done to distinguish what this bill does from C14, where both physical and psychological suffering are considered appropriate grounds to have your life ended with the help of the medical system. C7 also asks medical professionals to ensure that the person has been informed of various means available to relieve their suffering, including disability supports. But depending on where you live and the knowledge and assumptions of medical professionals, that's probably not going to be the same thing as having access to the supports you need. Knowing that an alternative to death exists is no good if you can't actually get to that alternative. Another couple of lines that give me pause are the reduction of witnesses from 2 to 1, as Dr. McQueen mentioned. Especially people with disabilities who rely on caregivers or who live in institutions. Think the retirement homes, again, whose horrors we've seen as a result of this pandemic. Anyone relying on the care of another is at increased risk of various kinds of abuse. And if the caregiver assists with filling out and witnessing to the completion of the form, while deliberately misinterpreting the person's wishes, her desire to die, then we have a problem. And again, I think all of this comes from a huge misunderstanding in the wider culture, which has traveled up to the government. People with disabilities perceived as passive recipients of care, people who are always suffering, always vulnerable, instead of people with rights and voices of their own that need to be honored.
Thank you for that, Taylor. Appreciate that. There was a powerful panel discussion a couple of months ago now in Ottawa with people from the disability community and disability advocates who were sharing very, very personal stories about how they are living with dignity and have fought for so long to be accepted and treated just as equally as everyone else in this country. And many people were expressing the concern that they feel like this is 2 steps backwards, because if there are people with disabilities who are eligible for euthanasia now, it's almost seen as their life is not got the same value as others. And it was, I know you were there, Taylor. It was a powerful conversation. We need to make sure that the voice of those with disabilities is front and center. These are the people that are very vulnerable in this discussion. So thank you for that. We've got a few people that have been posing some questions, and I appreciate your patience. We're gonna try to get a little more practical in terms of what can you do if someone counters with an argument here or there in something that you may present to them. So Christina, briefly, maybe you could tell us, what would you say to someone who thinks that, euthanasia in Canada now is a right, and so medical professionals should just, stop protesting? This is part of your job, and if the autonomy of the individual, when they want to do that, you should just respect their wishes.
For sure. Thanks, Neil. So I'm going to start off by clarifying some terms. It's not a right, it's a legal permission. So, and I think one of the things that we had to talk about that lifts off that whole notion of euthanasia being right is oftentimes there's this similar notion that there is a right to die. I want to dispel that too. There is no right to die. We're all going to die. That's a certainty. Conversely, for example, though, the right to life is not certain, because it is something that requires dependency and an external freedom which needs to be safeguarded in order for life to occur. This is the same for all other human rights, but most importantly, it's really important to talk about this notion of dependency a little bit, because it also lifts off the comment made earlier in this discussion about dignity. All human life at some point, it depends on others, which corresponds to our dignity and does not lessen it. And this is the reason, and the reason for that is because it can be mediated by compassion. So compassion, loosely speaking, means to suffer with, and allows us to give and receive, which are fundamental good desires of the human heart. So when, as healthcare professionals, we don't prolong suffering, and we should do all that is ethical to relieve it, such as palliative care, which I would like to point out too is not equitably available in Canada. This is particularly the case for specialized pediatric palliative care, which is this subset area that I explore as well. But the notion of a right to die is based on this idea of autonomy, which is, the notion of a right to die based solely on autonomy is therefore ethically redundant, because it is not unethical to be dependent on others when we are in need. But rights need to be extremely safeguarded so they're not abused. So patients deserve access to ethical care, but healthcare professionals, because they have a duty born of conscience, also need to provide and discern what is ethical care and only provide access to what truly is ethical care. So interestingly enough, the duties of the freedom of conscience right are for healthcare professionals to rigorously inform their conscience and then to follow it. So this approach actually offers a way to balance patients and provider rights by ensuring that life-affirming care, which is life-affirming care is that type of care that philosophically affirms that taking one's life is unethical. So by ensuring life-affirming care is offered across all phases of life, which actually include dying and death. So those are actually phases of life, and they deserve life-affirming care. So since taking the lives of others is a violation of the right to life, for example, and there is no right to death, and there's no right to euthanasia, healthcare professionals who are conscientiously refusing to perform euthanasia are actually doing their jobs, not the other way around.
Thank you. And Derek, let's go to you in terms of someone who might give you the argument of, listen, there's so many restrictions in place. Bill C-7 will ensure that people are safe. No one's going to have to do this against their will. How do you respond to that argument?
Yeah, it's an important issue to respond to, because that is a prevailing narrative that we have safeguards, we have protections. But the truth is, the reality is that our courts have consistently acknowledged that no system that legalizes euthanasia is entirely risk-proof. In fact, they've acknowledged the opposite. The Supreme Court of Canada, they noted that risks could be substantially minimized. They never said, though, that risks could be eliminated. In the Truchon decision from the Quebec Superior Court, Truchon, by the way, that's the litigation, that's the case that has led to Bill C-7 about opening up euthanasia to individuals whose death might not be reasonably foreseeable. In that case, and I just want to read this quote because it's a really important acknowledgement from the court that even in calling for euthanasia to be expanded, the court acknowledged this, quote, "No system other than total and absolute prohibition will ever be able to prevent every error." And I think we need to give that a name. Error in this context isn't a mistake on a math test, it's human life. The error that we're talking about is the risk that someone's life will be lost because they are wrongly euthanized against their true wishes. That is a deeply tragic, unjust outcome, and that's something that is happening. We've seen stories being told about patients who are being pressured to consider euthanasia against their will. They aren't even the ones initiating these conversations in some contexts. And I'll just close with this, and it's encouraging listeners and viewers of this webinar to check out the end of mission statement that was published by the United Nations Special Rapporteur on the rights of persons with disabilities. It's a very condemning statement from a person and an institution, the United Nations, that isn't necessarily ideologically opposed to euthanasia per se, but are very troubled by what they're hearing out of Canada. And in this end of statement, the Special Rapporteur observed significant shortcomings in the way that Canada is implementing our international obligations to respect, protect, and fulfill the rights of persons with disabilities. And specifically, the Special Rapporteur looked at our euthanasia regime. He noted that there was a lack of protocol to demonstrate that persons with disabilities have been provided with viable alternatives when eligible for assistive dying. This goes to Taylor's really powerful points about how assisted death is being presented as a solution, a general solution to suffering associated with barriers that individuals with disabilities face for reasons completely unrelated to them. These are societal issues that we're not addressing. The Special Rapporteur also described receiving worrisome claims about persons with disabilities in institutions being pressured to seek medical assistance in dying, and practitioners not formally involving persons with disabilities. This is a formal report from the United Nations Special Rapporteur. She has called on the federal government to respond to this. The government has not to date responded to her calls for reform, and instead of looking at ways that they can tighten these, the government is now looking to expand euthanasia, and that is deeply troubling on many levels.
Thanks, Derek. Those are some comments and some insights that probably most Canadians aren't familiar with. We don't hear a lot about that, but it's good to do that research. Thanks for that. I'm going to just go to Moira and Taylor, then we're going to take some questions because we've got a number of them, and I'm just keeping an eye on the time. Moira, in recent weeks, this COVID-19 situation, we've learned a lot in the public about conditions at these long-term care facilities in our province. And do you think there's a connection between the state of end-of-life care in our country and the demand for euthanasia?
Well, once upon a time, I don't think I would have said that, just as a matter of fact. But learning all that we have learned over the past couple of months about what does go on in our long-term care homes, and some of them, we have to be careful, it's not all of them, but in some of them, it almost makes it understandable why many of us would say something like, well, I don't want to end up in a place like that because it's appalling and the tragedy is quite something else. But that isn't, of course, the answer. I mean, the answer is the one that we've been talking about for decades, that what we really need to do is improve the long-term care homes themselves, the conditions in them. There obviously need to be supervisory orders that go into action as speedily as possible. At least the whole country now is aware of that, because the report upon report has been made about long-term care homes, and the problem has been a little bit like the disability community. The non-implementation of the reports, the lack of attention in all those areas. So coupled with what most of us have also been saying, and not just in response to euthanasia, but for its own sake, that we need palliative care. We need more and better palliative care. That's really, I think, the main answer that most of us see. These are human needs. We need to have the government come forward, put more money, etc., into improving the long-term care homes, the conditions in there. Again, that's a human need for our elderly. Surely we're going to respond to that. And as I said again, coupled with palliative care, it seems to be true that when people become aware that palliative care is a really good option, because most people still talk about control, they talk about fear of pain. They're very basic human, areas yet again. And the more we can persuade people that there are, to an extent, answers to both of those perceived problems, I think then we begin to come around to that kind of problem of what is going to happen. Is it really linked, the treatment in something like our long-term care homes, to a perceived need for euthanasia? The long-term care home is one part of the problem, but there are these other factors as well. And we need to keep pushing them, I think, to let people know that there really are alternatives.
Yeah, it's interesting. I think she was senator at the time. I think she retired now. Senator Sharon Carstairs that did her initial report on palliative care. And where was it? 15, 20 years ago now?
Yeah, she had two major ones, 2006 and 2010. Yeah, exactly, Neil. Neither one was implemented.
and we keep hearing the government talking about palliative care. And, when we talk about only a third of Canadians having access to good quality palliative care, it seems strange to me that we would say, let's try to give access to as many people as possible to choose the moment of their death, when we know, as you've said, Moira, that most people say it's the fear of pain or being alone. Palliative care can help take care of that. Why would we not get 100% of Canadians have access to palliative care before we try to figure out a way to hasten their death? So there's my little editorial point, but it just, every time you talk to a politician or someone about that, you say, you guys have had so much time to work on this palliative care. If you had that same energy that you're putting behind euthanasia, you'd have that solution 10, 15 years ago. So anyways, my little moderator comment there. So Taylor, final thought for you before we go to our questions from those who've been joining us. Can you think of any ways that people watching this webinar at home or listening can make a positive difference on this issue? What should they be doing?
As I've said all night, the debate often takes place in academia and government, two places that are not easy to reach. Definitely write to your representatives at the federal and provincial levels, but beyond and before that, take time to learn about the issue. Check out the Euthanasia Prevention Coalition, disability rights group Not Dead Yet, both the Canadian and US affiliates. Check out your local Center for Independent Living, which helps people with disabilities to remain in their own homes in the community and avoid institutions and nursing homes. And check out your local home care offerings.
That's great. And also we talk about helptheliving.ca, those the website we mentioned at the beginning of the webinar, where you can go and you can write to your local member of parliament. We had a few questions that have come in, a number of questions that came in. I'm going to try to get to some of them now. A number of them are around the political process, and writing to your member of parliament is a very effective way of doing it. People talk about petitions versus letters, that sort of thing. What I usually advise people to do is a personal letter always is best, as opposed to a form letter, because sometimes those members of parliament see them and they say it's a campaign. It demonstrates that there's concern, but a personalized letter is always great. There's a sample letter on the helptheliving.ca website, or you can take some of the points that were made by some of our speakers tonight and make those as well. The more personal, the better. A phone call to your member of parliament's office is really important. If they get 10 calls on an issue, that's on their radar. And even better is an in-person meeting. I know that many doctors in Ontario, healthcare professionals, and other concerned citizens of whether it's Ontario or other parts of the country have also met with their local representatives too. That's really important because those are votes. And to be crass about it, we're constituents who vote, and they should be concerned about that. We have a bit of a challenge now in that with our minority parliament, a number of the parties have kind of publicly said, the Liberals have publicly said that they are supportive of this bill. They introduced the legislation. The NDP, the Bloc, have also indicated a desire to even go further in some of these things. So you may have people pushing on the other side and saying there should be greater access. And so the Conservatives have talked about opposing certain elements of the bill as well. So we're in a challenging situation right now politically because you know, in terms of the majority of votes in the House tend to be on the side of those who are favoring expansion. But those are a few of my comments just in terms of the political process. I'm going to ask, I want to see if I can get this here. Oh, for Derek, quick one for you, Derek. So one of the questioner says, I was always under the impression that Parliament makes laws and the courts interpret. This seems the opposite. How did we get to this point in our society that the courts are making the laws?
Well, that's a very large and important question, and a lot can be said about it. But essentially, this is the result of Parliament enacting the Charter, and the Charter has really granted to courts a much more significant role, not only in interpreting the law, but in striking down laws which the court deems unconstitutional. And that's what happened with the Criminal Code prohibitions, the Criminal Code prohibition on assisted suicide. Now, Parliament could have responded with a law that continued to prohibit euthanasia and clarify what the objective of the law was. Part of the problem in Carter was that the court looked at the law and interpreted its purpose very, very narrowly. And we and a number of other organizations urged Parliament to say, instead of scrapping this law, go back to the court with a re-articulated purpose to more clearly enunciate what it is that you're trying to do with this ban. This is something in constitutional theory called dialogue, that instead of the court just imposing its will on Parliament, that's not really what the system is designed for. What it's designed for is for where there are competing interpretations of the law, competing interpretations of human rights, that both the courts and Parliament have an important role to play in ensuring that the proper balance is struck. But Parliament did not do that. And so I don't think it's fair for us to entirely blame the courts for these decisions. The courts are doing their job in interpreting the law. We might disagree with their interpretation. I certainly disagree with the Supreme Court's analysis in Carter, but Parliament also has a role here. And what we're even seeing with Bill C-7 is, instead of appealing the Quebec Superior Court decision, which Parliament could have done, they just accepted it, didn't even allow it to go to an appeal court or even to the Supreme Court of Canada, just accepted the lower court trial judge's ruling and have now gone to completely restructure the law. So this is not just a court issue, this is a political issue.
Thanks for that, Derek. Christina, how about this one for you? Question saying that considering the social factors driving medical assistance in dying, who can we empower to offer compelling palliative alternatives to euthanasia? Is it occupational therapists or social workers? Any thoughts on that, how we might be able to coordinate those services, or who we might turn to offer alternatives?
Absolutely. Thank you to whoever asked that question. And thank you also to all the participants here today. It's fantastic. So there are quite a few things that you can do. There are a few initiatives that already exist. So for example, there's Palliative Canada, which does a fantastic job led by Dr. Jose Pereira. And what their mission basically is to educate every healthcare provider in palliative care. So they offer workshops, they offer weekend courses, and you can build on your levels of knowledge of palliative care. Their goal being that every healthcare professional should be able to provide palliative care. So if you're a nurse, if you're a paramedic, if you are a chaplain, if you're a physician, whoever you are, you can take those courses and become skilled in that yourself and encourage other people to do so. I've had students already, grad students who approach their clinical areas and said, ask their managers to get on board. And sometimes in hospitals, there's a continuing educational fund. So you can actually, if you're a nurse or physician or pretty much any kind of healthcare worker, you can actually ask your managers and your leaders in the hospitals to fund this training, so you can bring that into hospitals and get more, more awareness about that at that level. You can also, you can certainly investigate the issue a little bit more yourself and advocate it for it in terms of writing to your local parliamentarians. You can talk about it with friends and colleagues, and you can also get yourself immersed in the literature, because there's a lot of fantastic work being done in palliative care for people specifically in Ontario and the Toronto Archdiocese. There's Dr. Kim Widger, who's doing some great work in pediatric palliative care at U of T. There are other physicians like Franco Carnevale is doing some fantastic work at McGill around children's, specifically related to children. So I would say that those are some great options and highly feasible, because pallium is already quite well known in the community.
Thanks for that, Christina. And a number of people who also have comments. We had a comment from one participant who is on a board of a hospital and talked about raising some of these issues and almost really felt intimidated and told to change the way your language it's not sensitive enough, this sort of thing. And Moira, I don't know if you want to mention a word or two about that in terms of the whole force that we're all feeling to use this kind of language of death with dignity and medical assistance in dying, and it's almost, you're seen as insensitive if you're not using the right language these days.
That's right. In many areas, and in this one in particular, getting to the stage where you're being told what to say. I mean, we're talking about Charter of Rights and freedom of conscience, freedom of speech. It's amazing what's going on professionally, in particular, about the very language we use. And sometimes the language has been wrong and has been insensitive in many of these areas too. But the whole question here, I think, is it's almost like a creeping for many of us, and I feel very strongly, I feel for people in directly working in some of these situations, ethicists, nurses, doctors, etc. And I know some of them, I've heard some of the problems, and I know some of them have lost their jobs because of the way that they did speak out, using just the correct language for what actually goes on in these procedures. And it is intimidating for them, and I think that climate of fear is something that works very, very much against people who in their conscience feel very strongly about what they believe and are not being insensitive in either what they say or what they do, but are simply putting forward what they believe is the right thing to do. And we talk again about rights and that whole question of that freedom being enshrined in our charter. And as Derek's pointing out, the interpretations of the courts, Supreme Court's been really interesting, I think, in how it has dealt with even the whole question of conscience. There's a ton of literature there at the legal level about what conscience means in Canadian law, and it's far from settled. So I find when it's not settled at that area, it's very difficult then, you know, that trickle-down effect in helping people work out just how far we can go in terms of talking about conscience. We don't all seem to mean the same thing. So that question of language, Neil, is very, very important. The confusion that exists when we think we're talking about the same thing, sometimes we're not. But it does worry me, that sort of coercive back. And I think is meant to quieten us down, is meant to dumb us down. It's back to that question, speaking as a theologian, if I make an argument that's perceived as religious, people will tend to dismiss it. The fact that I have facts and figures and some academia behind me to talk about statistics, etc., becomes almost irrelevant. So I think the personal fortitude that many of us pray for, because of our faith stance in these areas, which is impelling us to do what we consider to be the right thing, is something that I think we need to beef up on, really. And just as usual, just keep on that persistence and fortitude in saying what we truly believe. And at the same time, I do believe we can be sensitive to other people. I only wish they could be as sensitive in return.
That's a good point. Thank you, Moira. And I know, I'm just looking at my time, I know we've gone a little bit over the hour. We're getting more like an hour and a quarter here. Thanks to everybody who stayed with us. We're just going to take one or two last questions and then we'll wrap things up. Derek, I did have a question from someone about those with mental health issues. And is that in the bill? Where does that stand? If you could shed some light on that.
Yeah, absolutely. Great question. So Bill C7, I think Taylor mentioned this already, it does make clear, and this is one thing that's good about Bill C7 that I think we can support. It makes clear that a mental illness, mental health illness is not in and of itself an eligible condition to give way to euthanasia. So if one's only underlying condition is a mental health related condition, they could not on that basis alone seek access to euthanasia. However, where it becomes less clear is whether someone who has a combination of both a physical illness and a mental illness, if those together combine, can create the irremediable and grievous condition that create eligibility. A number of physicians have interpreted it as exactly that. As Taylor mentioned, psychological suffering is something that the legislation already contemplates as being relevant to the eligibility criteria. And in fact, we have seen, going back to some of the data that we have from Quebec, in the vast majority of cases, 95% of cases, patients who have sought and been granted euthanasia have been granted euthanasia not only because of their underlying physical suffering, but because they also reported psychological suffering. In fact, it's only 5% of cases where physical suffering alone was reported. And when we look at the psychological suffering, what's being reported on these forms for why people have sought and received euthanasia, it's things like loneliness, isolation, fear of how death will come, fear of being a burden on loved ones. These are all being encapsulated under the psychological suffering rubric, and that's devastating. It's heartbreaking to think that this is what it is considered an eligible psychological suffering to create eligibility for euthanasia. And so that's really sobering, I think, and something that we need to be really mindful of moving forward. But as it stands now, mental illness in itself is not considered a grievous and irremediable condition which would allow an individual to be eligible for euthanasia.
Okay, great. Thanks for that, Derek. Appreciate it. I'm going to give a last word to Taylor. We had a question about, people talk about dying with dignity. What about living with dignity for someone representing the disability community? What does that mean to you when you hear that phrase?
Living with dignity to me means being supported to be able to live life on your terms the same as a person without a disability would. Some of the areas that come to mind first are the inaccessibility of housing, financial disparities, for example, people who rely on government disability supports. The amount of money one receives in a month can't pay for rent on most apartments. As well as keeping people out of institutions where they have no say in their schedule, who can visit them, what their space looks like, who can care for them if they end up in an abusive situation. I think one of the most important things we can work for is reform and hopefully elimination of institutions, and replaced with supports for people to live in their own homes.
Thanks for that. And we could have a whole nother webinar on that discussion. It is an important one. I want to thank everybody for this really rich conversation and insightful conversation. As you could tell by listening to the panelists that we had, they're all very well versed in their respective areas of expertise, and they know a lot about this issue. Let's bring up on the screen, if we may, one last time, if we encourage all of you who are watching today and listening to please write a letter to your local member of parliament. Visit helptheliving.ca. Very simple to be able to do that. Better yet, if you want to tailor your own message, send your own individual letter or make a phone call to your member of parliament's office. Obviously, the parliament is now kind of suspended sitting at the House of Commons until September. We're going to have to see where it goes, because there are still some legislative wrinkles that are going on, Derek, as you know, in Quebec. That extension that the federal government asked for kind of expires mid-July, so there's going to need to be a decision made on that. So it's hard to know how quickly this is going to move. Federally, they will have to have committee hearings. Someone did ask a question about what's the Archdiocese doing. We're working with many other faith communities and people from the disability community, medical community, legal community. In partnership, will participate in those committee hearings. Cardinal Collins has done that in the past. We've gone on the Hill, met with members of Parliament, senators, staffers about this. We'll continue to be doing that. We'll be sharing information with parishes, certainly in the Archdiocese of Toronto, and we're happy to share that with any others. So please do visit the website. Take a moment to contact your local MP, and at the provincial level, you can also contact, and certainly in Ontario, your MPP, and ask them for conscience rights legislation that will protect healthcare professionals from having to be part of euthanasia. Talk to your family, your friends, your neighbors about this issue. Talking about end of life and dying is not a real positive topic that a lot of people like to talk about. Sometimes culturally, it's not something that people like to even acknowledge or discuss. We need to have those conversations with our neighbors, our friends, our family. And then at the Archdiocese of Toronto, we've obviously got this Parish Action Initiative that we've started up to have webinars like this to be able to learn more about these issues. So we encourage you to learn more about that if you'd like to get on our Parish Action mailing list. I know that Mark Brosens, who's coordinating that initiative and has done so much to prepare for tonight, we thank Mark, has got some information on the screen to help you follow the link to sign up with that. And we also have a microsite on euthanasia at archtoronto.org/euthanasia. And there are many other groups, Euthanasia Prevention Coalition, doing wonderful work across the country, and others. I know the St. Thomas More Society is having a webinar on conscience rights in another week or so. So there's a lot of different information out there. We're also going to have the PowerPoint presentation made available for download. And with that, I want to thank everybody. I want to thank our panelists, Christina Lamb, Taylor Hylett, Dr. Moira McQueen, Derek Ross. I'd like to bring in Cardinal Collins as we wrap up this evening for some final thoughts and maybe a blessing for everyone. And Your Eminence, I thought there was a really poignant comment that we received in the question box that said, how can we best evangelize a culture that thinks individual choice is king and does not see our interconnectedness to each other, that is, that we do not make the choice to take our own life in a social vacuum, and to God, that is, that we are not the masters of life and death? And how can we make people see that rather than impinging on our freedom, it actually fulfills and completes it? A very powerful message, and I'm sure that one that maybe you just share briefly as you wrap up this evening with us, your thoughts.
Well, that's very, very true. It's a profound issue that has been raised in that remark. We know why people seek euthanasia. Sometimes the fear of physical pain, it's fear of isolation, things, all of which we can in different ways help to alleviate, especially through things like palliative care. But there's another side of it, and that's what is just mentioned there. And I remember speaking with a politician once who really was, it's the idea, it's the autonomy. I can do it. I've got that power. And it seems a liberating thing, but in fact it's enslaving when we become enslaved by our own will. The greatest freedom we have is in our cooperation, our love, and our relationship with other people. And when we have people who feel that their ability to exercise their own will as a sovereign, it really goes right back to the Garden of Eden, to be in command. Well, none of us are in command, and we find that that kind of a thing, I think, is very, very spiritually destructive. It's just what comes to my mind is St. Augustine. He was seeking that kind of thing in so many of the wrong places in life, to be in command. And when he found, you have made us for yourself, O Lord, and our hearts are restless till they rest in you. If we forget, like our Lord says, forget yourself and you will find yourself, you'll die that you might live. That is the message of life. And in so many ways, it is not, our world is impoverished in that, the lack of that. I often think of the movie The King's Speech in a lot of ways. It's a very, very good movie. But it is about the futility of one person, the charming older brother, who thought he would find happiness in his ego and his ability to make what he willed, make it happen. And there is no happiness there ultimately. What is happiness in the younger brother, who turned out to be the father of our current queen, happiness in giving himself to the country, to the people. And in giving himself to that, he found himself, he became great. And that's what we're all invited to do. And this, apart from the specific issue of euthanasia, it's that broader issue that we need to look at in many other areas of life. The dictatorship of relativism, the dictatorship of the autonomous ego. I often think that, you know, the smallest letter in the alphabet is I, and yet it can cause most trouble. It's right at the heart of the word sin. And I think it's ultimately the ego is what the problem is. There's no future there. So in that, if not, we get into the Trinity, Father, Son, Holy Spirit, it's relationships of love. And we're not in command. We think we are. You know, we're like the captain of the Titanic blasting through the icebergs, you know. So with that, I thank you, Neil, and Mark, and for organizing this, and those, the panelists who took part. This is really important to understand this more thoroughly from many different perspectives. And then having understood it more fully, because we do seek reason to understand, reason and faith together, but certainly reason, and then act, to find attentive and thoughtful and careful and effective ways of helping other people to understand. I just was thinking, wouldn't it be so good if people who are encouraging, pushing euthanasia were to be on in this conversation? Maybe they were. I hope they were. I hope there were some. To see this, and it's our role to make that more widely known, and in the ways that you were mentioning, that Mark has these different ways we can make our voice heard. We need to do that. So many thanks for all for participating in this, and I'll just give you a little blessing as we end. May the Lord bless you and keep you. May the Lord keep us all faithful to His will, and to truly live lives that are full of faithfulness and love and life, to give God's life and blessing to one and all. In the name of the Father, the Son, and the Holy Spirit. Amen. Amen. God bless you. Many thanks.
Thank you, Your Eminence. And thanks, everyone, for joining us. We really appreciate you taking time out of your busy days to be with us. Thanks again to the panel. And please continue to learn more, be informed about this. We'll be doing our best to get the word out, and we hopefully can rely on you to do the same. So thanks very much. Stay safe and healthy during these difficult days. God bless, and we'll see you very soon. Good night, everyone.
Thank you.
Good night.
Thank you and good night.